Hi, I'm Hillary Ramroop. I'm a brain injury certified physiatrist. I work over at Glen Cove Hospital. Today, I will be speaking about one of the most frequently reported symptoms after concussion, which is sleep disturbance. Following a concussion, the role of sleep becomes even more critical, and poor sleep can hinder a patient's neurologic recovery. So it's really essential to address sleep issues early on to promote optimal recovery in our patients. So why do we need sleep? Whenever our calendars become crowded with obligations or events, sleep is often the first thing that we sacrifice. The exact purpose is not fully known. However, we do know that sleep is critical for our mental and physical health. We know that during sleep, especially during REM, rapid eye movement, and slow wave sleep, deep sleep, the brain consolidates memories and processes emotions. During deep sleep, the body enters a state of cellular repair, producing growth hormones which help to rebuild our tissues and muscles. Sleep also influences hormones such as leptin, which is a satiety hormone. This decreases when one is sleep deprived. Ghrelin is a hunger hormone, and that hormone increases when one is sleep deprived. Increased blood concentrations of ghrelin may facilitate weight gain, especially if it's persisting over an extended period of time with patients that have sleep loss. Poor sleep also affects our metabolism. It's associated with obesity, insulin insensitivity, diabetes, increases the risk of high blood pressure and stroke. So sleep is not a passive state. So we know sleep is important for optimal health, but there really was little information regarding the amount of sleep that people need. So in 2020, the United States Department of Health and Human Services created a sleep health objective. And this was aimed to increase the proportion of adults who get sufficient sleep. It was a federal initiative, and at that time, the data had showed that over 1/3 of American adults reported they were sleeping less than 7 hours per night. So they developed a consensus just to give recommendations on the amount of sleep needed to promote optimal health in adults. For adults age 18 or older, they recommend at least 7+ hours of sleep. And, previous studies have found that having less than 7 hours of sleep led to negative health outcomes and early mortality. And this was actually published in the Sleep Journal. I just wanted to briefly go over the normal sleep stages. So sleep stages are divided into non-rapid eye movement and rapid eye movement. Stages N1 to N3. This is the non-rapid eye movement. Stage N1 is a very short duration sleep. It's considered light sleep. N2 is where memory consolidation happens. N3 is considered the deepest stage of sleep. This is where tissue repair occurs. And REM sleep, that's one that most people know about. This is actually where dreaming occurs. So sleep disorders after concussion. Sleep disturbances are really common reported in concussion patients, but they're rarely assessed in outpatient settings. Poor sleep may not only signal injury severity, but it really impairs one's neurocognitive recovery. Anywhere from 30 to 80% of individuals report sleep impairments after a concussion. And research has shown that poor sleep during the acute phase of concussion is linked with prolonged or worse recovery. Patients with acute sleep disturbances have nearly 50% higher odds of a prolonged concussion recovery. They report symptoms months after their initial injury. Patients, they tend to report a decrease in total sleep time as well as efficiency of sleep. They may report increased awakenings after sleep, which all contribute to poor sleep quality. A bit about the pathophysiology of sleep. So concussion-driven pathophysiology disrupts sleep through multiple mechanisms. There's a neuroinflammatory cascade and microglial activation. So this leads to a surge in catecholamines. We have noradrenaline, pro-inflammatory cytokines, which promote arousal, suppress deep sleep, and disrupt lymphatic clearance, which is what gets rid of the waste in the CNS. We also have a neurometabolic cascade and ionic imbalances that occur. Mechanical shear forces from injury can cause diffuse axonal injury, high extracellular potassium, there's low sodium, calcium, and this mirrors patterns seen during wakefulness. There's also disruption of neurotransmitters and neurohormonal systems. Any type of brain injury, whether it's mild or severe, can lead to dysregulation of the sleep-wake cycle. Lower levels of the CSF neuropeptide hypocretin-1 is associated with excessive daytime sleepiness, especially in the acute phase of TBI. There's an imbalance between GABA and glutamate. GABA is the brain's primary inhibitory neurotransmitter, and it promotes sleep. Glutamate is an excitatory transmitter, and it's involved in wakefulness. After concussion, there's often excessive glutamate release acutely, and that leads to excitotoxicity and neuronal dysfunction. Over time, altered GABA signaling can result in difficulties initiating and maintaining sleep. The imbalance between GABA and glutamate may underlie disrupted sleep architecture. There's also melatonin reductions that can occur, which can impair REM sleep. Sleep initiation, and also reduce circadian rhythm stability. We can have excessive cortisol and the hypothalamic pituitary adrenal axis dysregulation, leading to elevated evening cortisol levels, which in turn impairs sleep initiation. Concussions can also disrupt the circadian rhythm. As previously mentioned, this is the body's internal 24-hour clock. These are just structures that are involved in sleep-wake cycle, arousal. So this disruption can impact various physiological process. So any of these structures, if they get disrupted, this can alter sleep patterns, hormone production, body temperature, or metabolism. And if there's axonal disruption, this can affect brain regions, including the suprachiasmatic nucleus and the pineal gland. The pineal gland, that's what produces and releases melatonin. And that can, like previously mentioned, it can lead to issues initiating sleep, staying asleep as well. This is a nice feedback loop that I found from Donahue. This was a review article, and they talked about the pathophysiology of sleep and concussion. So this basically summarizes the past few slides of the feedback loop that's involved with concussion, with the neuroinflammatory response, the sympathetic nervous system being activated, leading to hyperarousal with the noradrenaline, also the ionic imbalances that happen as well. So as previously mentioned, sleep disturbances can be reported anywhere from 30 to 80%. So it's really a wide variety and percentage that can happen. The most common reported sleep disorder is insomnia. This is characterized by poor sleep quality. It can be increased time to fall asleep, waking up in the middle of the night with trouble falling back asleep, or awakening too early and not feeling well rested. There's also hypersomnia, which is the increased need for sleep. Patients are often sleeping for long hours. Circadian rhythm disorders, which are disruption of the normal 24-hour cycle of body patterns, such as melatonin secretion. We also have obstructive sleep apnea, which can contribute to why a person is not feeling well rested and not sleeping. So this is due to airway collapse during sleep, and some features are snoring, gasping, non-restorative sleep. With excessive daytime sleepiness, there's an uncontrollable need to sleep, oftentimes falling asleep at inappropriate times, such as while sitting. With narcolepsy, this is also excessive daytime sleepiness, but it's usually associated with cataplexy, which is a loss of muscle function. I took this picture from McCarthy's 2010 review article. They also talked about clinical problem solving as providing a framework for understanding why patients have sleep-wake disturbances. So McCarthy talks about 5 key sources that we want to keep in mind when we're figuring out why a patient could be having disrupted sleep, especially in complex cases. So he talks about 5 different sources. So circadian misalignment, pharmacological reasons, medical factors, psychiatric and psychosocial factors, and primary sleep diagnoses. So this just goes into those 5 factors that he talks about. So I just put this in a chart format. So primary sleep disorders, these are independent medical conditions that disrupt sleep architecture or timing. So this would include our obstructive sleep apnea patients, patients with restless leg syndrome or narcolepsy. For circadian rhythm disruption, patients who have jet lag or shift work disorders can experience this. Also, keep in mind, patients with psychiatric disorders can have impaired sleep because psychiatric disorders can directly impair one's sleep. Anxiety disorders can cause sleep onset insomnia, racing thoughts. Patients who are depressed, they may wake up early in the morning, or they may have hypersomnia. Patients suffering from post-traumatic stress disorder, they can have nightmares, hyperarousal, and fragmented sleep. We should also take into account polypharmacy, medication use, and side effects of those medications that can directly or indirectly disrupt sleep. So these include our stimulant medications, ADHD medications, caffeine, alcohol intake, the benzodiazepines as well, which may reduce deep sleep. Also, other medical factors, such as musculoskeletal complaints, patients with pain, our BPH patients who are getting up frequently in the night to urinate. So how does sleep disturbances hinder one's recovery? Disrupted sleep, particularly in the acute phase, we know that it can exacerbate one's symptoms. Improving sleep quality can promote a faster and more complete recovery. We know that poor sleep worsens common post-concussion symptoms that patients report, such as headaches, fatigue, difficulty concentrating, and irritability. We know that certain stages of sleep are important for memory consolidation, and disruption of these sleep stage can affect cognitive recovery, can cause emotional lability as well. And this really can create a vicious cycle when symptoms disrupt sleep, and then poor sleep further intensifies one's symptoms. We previously spoke about neuroinflammation, which contributes to symptoms as well. And again, these disturbances can exacerbate inflammation and impede one's recovery. So the exact mechanisms are not fully understood in terms of how, the pathophysiology. And so subjective tools and objective measures, these are what we can use to evaluate sleep disturbances in our patients. So subjective tools, these are sleep logs and questionnaires. One questionnaire is the Pittsburgh Quality Index. This is a self-reported questionnaire that's used to assess sleep quality and disturbances, usually over a month time period. For objective measures, we have polysomnography. This is what's known as the sleep study. actigraphy, and multiple sleep latency test. With polysomnography, this is our sleep study. It provides data on sleep onset latency as well as monitoring of one's heart rate and blood oxygenation. It provides a detailed assessment of sleep patterns and helps to diagnose sleep apnea, narcolepsy, periodic limb movement disorder, and also REM sleep behavior disorder. This is really the gold standard for diagnosing sleep-related breathing disorders. Actigraphy, this is what I have a picture of here. So this is a non-invasive method used to assess sleep-wake patterns. This measures activity using a small watch-like device called an actigraph. Usually patients wear it on their non-dominant wrist. Sometimes they could wear it on their ankle as well. They should be wearing it for at least a couple weeks to help capture the sleep patterns in a person's natural environment. So there's an accelerometer which detects and records movement and activity levels, and they collect data and then they analyze it through certain algorithms which help to quantify the total sleep time that one has, sleep onset latency, sleep efficiency, and wakefulness after sleep onsets. And also, please don't forget our comorbidities when we're evaluating patients. So we do want to make sure that we're screening for mood symptoms, other symptoms that patients could be having that are contributing to why they're not sleeping, such as pain, and if they're also having headaches. This is the same thing. It's just put into a tool format just to make it a little bit easier to read. So management. Early in the injury phase, we really should monitor sleep patterns and educate our patients. That starts with sleep hygiene recommendations. So sleep hygiene recommendations, this includes maintaining a consistent sleep-wake cycle to regulate the body's natural sleep-wake cycle. So we want to really limit our naps during the day, avoiding caffeine and alcohol before bed, using the bedroom only for sleep and intimacy, creating a cool, dark environment for sleeping. Studies have shown that cognitive behavioral therapy significantly improves sleep with really long-lasting benefits. Light therapy, especially morning blue light, helps to realign circadian rhythms and reduce fatigue. Daily exposure to bright light, more than 10,000 lux for at least 20 minutes. This can help to regulate the body's internal clock. And of course, let's not forget rehab. So exercise, are keeping a healthy lifestyle, this, and also cognitive stimulation. This helps to promote better sleep. I wanted to talk a little bit more about cognitive behavioral therapy because this is the gold standard of first-line treatment, especially for our chronic insomnia patients. This is really evidence-based. It works by identifying and changing the thoughts and behaviors that one may have that interfere with their sleep. Key components include stimulus control. So this is reassociating the bed and bedroom with sleep. There's sleep restriction therapy, which means limiting the time in bed to consolidate sleep and help improve one's sleep efficiency. Relaxation techniques, such as learning methods to reduce anxiety and promote relaxation before bed. This includes like deep breathing exercises and biofeedback. Cognitive restructuring, so challenging the negative thoughts and beliefs about sleep, and also sleep hygiene education, so reinforcing good sleep habits. And then a little bit about pharmacology. So melatonin, that's really the first line medication that's really used for sleep. This helps to reset our circadian rhythm. And as previously mentioned, we know that melatonin can be disrupted with any type of brain injury, whether it's mild or severe. We can also try a low-dose antidepressant such as trazodone or mirtazapine, but we do want to be mindful of side effects. Our stimulant medications such as modafinil for daytime sleepiness that a patient might have. And then, of course, treating obstructive sleep apnea with CPAP, BiPAP, other oral appliances. And this model illustrates how physical, psychological, and cognitive factors are really interconnected, and they can amplify or prolong recovery challenges after a concussion. These elements don't exist in isolation, but they influence each other. So chronic sleep can worsen a patient's mood, mood can increase pain, and pain can disrupt sleep. So there's a feedback loop that really hinders one's recovery. So we need to take into account everything and all these factors when dealing with concussion patients. So some takeaways, sleep disturbances are really are common and they're under-recognized sometimes with concussion patients. The pathophysiology is multifactorial, involving inflammatory, metabolic, hormonal, and circadian rhythm disruptions. We do want to take a stepwise multidisciplinary approach, and we can start with non-pharmacologic strategies such as cognitive behavioral therapy, a low-dose melatonin if needed, and of course, sleep hygiene. We know that underlying medical conditions can significantly contribute to sleep disturbances as well. Those are the references, and thank you, everyone.
Thank you, Dr. Ramroop, very much for that. Anybody have any questions for Dr. Ramroop? Please just, you can unmic and ask a question. Nobody? I'll give it a second.
I don't
Sure.
necessarily have a question, but I have a comment, if that's okay.
Sure. Dr. Landry?
Can you hear,
Yeah, we can
hear me
hear you.
okay?
Yeah, we can hear you. Yeah.
Okay. Sorry, I guess my service is not so great here. So I just thanks, Hillary. That was great. I just wanted to comment on one thing regarding sleep. The one of the big things that I commonly assess in patients, I don't know who else does this, is for iron deficiencies. You see it closely related not just to things like periodic limb movement disorder and restless leg syndrome, but just generalized poor sleep. We know that iron plays a huge role in dopamine synthesis. It probably also plays a role significantly in serotonin synthesis. So in individuals who don't respond well to melatonin, if I haven't checked it already, which I usually have, I'll check their iron status as well. There seems to be some possible mechanism related to that where, iron is needed to make serotonin. Serotonin is converted to melatonin, and hence, even with giving them exogenous melatonin, it may not seem to do the trick. You just have to be careful on how you're assessing for the iron deficiency. Anemia is not enough. Most of these kids have iron, or at least I see kids. Most of my kids seem to have iron storage deficiencies. So checking those ferritin levels, TIBCs, et cetera, and then not paying attention to the normal values because they're terrible. Making sure those ferritins are above 50, or checking a soluble transferrin receptor in those people those women who might be on birth control. It seems to be a huge thing, at least in my population, an easy thing to treat and plays a role in addition to everything else that Dr. Ramroop already mentioned.
Thank you, Doctor. Thank you. Anybody else? Anybody have any questions or comments?
Yeah, I had a question. Thank
Sure.
you, Dr. Ramroop. What dose are you starting modafinil on, and what are your criteria to use it?
Sure. So for me, I actually use modafinil mostly for the brain injury patients that I treat. Usually it's 100 milligrams that I start with. For concussion patients, I don't typically start them on modafinil unless they're very fatigued throughout the day and they really can't get through their day. I really try to optimize their sleep at night first. So we'll start usually with melatonin. If that doesn't work, then we'll try Rosarum. If that doesn't work, then trazodone for sleep. And usually trazodone tends to work for them. And again, with modafinil, it's usually 100 milligrams. I tend to use it more on the brain injury patients here inpatient. But I have given it to a few concussion patients who really, it's been months and they're still really fatigued throughout the day, just to kind of help more so with fatigue, daytime fatigue, and not being able to get through their day.
Thank you.
You're welcome.
Thank you, Dr. Beeford. Anybody else? No? Okay. All right. So I'm just going to stop the recording, and if everybody will give me a minute, I'm just going to reshare my screen. And thank you again, Dr. Ramroop, for that.
Thank you, everyone.